and the International Society for Bipolar Disorders that create the most recent up-to-date practice guidelines, they recommend lithium first line for new onset bipolar, and only 1 in 40 are getting it. The sedation is lower, the weight gain is lower. This will surprise people. In all the controlled trials of lithium, when they stack them up in meta-analyses, there is zero weight gain on it. That doesn't mean that nobody gains weight on it. Some people might lose some might gain some, but on average, there's zero weight gain.
Somebody get this guy some help!
Or, put more simply,
If you need help like this guy, call your own doctor.
Why do you think lithium, a natural element that we ingest and tolerate daily at low doses, and is recognized as an essential trace element by the World Health Organization, is so underutilized?
Yes, thank you. And that 1 in 40 comes from the same number you're giving. I just added to it the fact that we also missed the diagnosis. So when you get misdiagnosis plus wrong treatment, you're absolutely right. And the International Society for Bipolar Disorders that create the most recent up-to-date practice guidelines, they recommend lithium first line for new onset bipolar, and only 1 in 40 are getting it. So truly amazing. And why is that? Well, lithium has had a strange journey. So I think if I just tell the story, our audience will understand why. Lithium was a very popular health spa treatment. It was an ingredient in 7-Up, 7, the molecular weight of lithium. And people would go to health spas to drink lithium water. So before 1940, 50, lithium was seen as maybe the way we look on omega-3s, like just a really healthy nutrient. Then in 1949, the cover of the major medical journal JAMA, they published a series of all these deaths because for the first time on lithium, people were able to use lithium as a salt substitute. You know, people with blood pressure, they got to not eat so much salt. And for the first time, instead of drinking a little lithium water, they were able to just pour it on. And we now know from that study that lithium can be toxic at high dosages. So pouring lithium on freely is dangerous. And that made major media news. I know most of us aren't thinking about what was in the news in 1949, but the trace remains with us. So that left a bad taste in doctors' mouths about lithium for a good 10 or 15 years. Then Morgan Shu and John Cade and other doctors found that it helps depression and bipolar disorder. So it slowly became a medicine for that condition, really kind of grandfathered in the late 60s and early 70s. So a long delay from food substitute to medicine. And the reason there's a long delay is there was no financial interest in lithium. It's the third element to enter the universe, so it remains very generic and long since off patent, and no one can make money off of lithium. So when it entered, there was never any fanfare. And people who lived through that time told me about how they would go to conferences, and it was always, even in the 1960s and 70s, in the back room, that the nerdy doctors with their cheap old ruffled clothing were poring over lithium manuscripts while everybody else was in flashy auditoriums with fine linens and white glove service, getting dinner and hearing about the latest drugs. So that was the pattern for many years. That remained the pattern when I stepped into this. Sometime around 2001, I went to the APA meeting, and there was the late Fred Goodwin, who was the director of NIH. And I knew he was one of the great scientists of our time. He was giving a talk on lithium in the back room with no windows. And so I skipped out on the 3-course meal and went to his talk, which only about 10 people showed up for. And I was like, this is the most famous speaker here. No one's coming. And learned all about how to use lithium from him, and learned all about the research that was not getting publicized. So we have two main reasons why it's not being used: lack of publicity, stigma, because saying something helps bipolar doesn't really lend it to the general public as something they want to take. And the third reason is a little difficulty in using it, because if you go too high on it, it could be toxic. So doctors like to stay away from that. And in fact, doctors tend to see then that lithium is deadly, where what you're telling us is the opposite, that patients live 10 years longer on average with bipolar if they take lithium.
What do you make of the side effect profile if you're able to avoid in perpetuity getting to a toxic level for that person?
Then I think lithium is fairly well tolerated compared to other treatments for bipolar. So it's going to have a 1 in 28 rate of sedation. People hate sedation. Or the others, it's like 1 in 5.
But in terms of that 1 in 28, which again, as you just pointed out, is so much lower than its comparators. But at what dose is that 1 in 28 sedation rate indicated by or related?
That's going to be from studies using any kind of therapeutic dose, so varied doses. So somewhere in the range of 0.6 to 0.8, maybe even some with 1.0. So there might be a little more sedation as you go higher, but I don't tend to see that myself. What I do see is people, they complain of their thoughts being slowed down, feeling a little more like emotionally flat at a high dose. I rarely use a high dose, so it's not an issue on the lower dose. So the sedation is lower, the weight gain is lower. This will surprise people. In all the controlled trials of lithium, when they stack them up in meta-analyses, there is zero weight gain on it. That doesn't mean that nobody gains weight on it. Some people might lose some might gain some, but on average, there's zero weight gain. So sedation low, weight gain low. For cognitive problems, I think that's more dose dependent. And there it's kind of in the middle, kind of similar to carbamazepine, but better than Depakote. And for the antipsychotics, probably about the same. Some antipsychotics are worse for cognition, some are better. So for the side effects that most people care about living with day to day, it's a little more favorable. And the other big news is that people don't want to take lithium or prescribe it because of fear of kidney damage. But we now have the last 5 or 10 years, about 5 or so large studies showing no kidney damage, which was surprising. Most of these are showing no kidney damage relative to other mood stabilizers in bipolar. We already know that bipolar itself, because it stresses out the whole body, is going to impair the kidneys and the kidney health. So why is that then, we have to wonder, when there were these profound cases in the 1970s that raised everybody's alarm of real changes in the kidneys on lithium that were not otherwise explainable, and that led to its bad reputation. Well, if we dig deeper in those studies, they did find some kidney injury if the dose went above 0.8, which generally we're not supposed to go above unless they're super manic and need a higher dose. So if you can keep the dose at 0.8 or below, as you would for depression, as you would for bipolar 2, and by that I mean bipolar 2 where you don't have full mania, you just have hypomania, then it's looking like there's going to be no detectable renal injury on lithium.
Yeah, I think I've seen a couple of papers, one in, I believe it was animal data, that showed that a low dose of lithium was actually protective of the kidney during an acute kidney injury, maybe lending credence to the fact that it can help to prevent apoptosis or programmed cell death, which Dr. Rith Al-Malik, I'm not sure if you're familiar with Dr. Al-Malik.
Great.
Yeah, he's wonderful. I trained under him. He was such an incredible and great influence on my training. I believe that he told me, and this will kind of parlay into my next question. I believe he told me that the makers of Depakote at one point created a very short-term study that showed that lithium created significant weight gain compared to Depakote, and they utilized the fact that lithium draws additional water into the cells and therefore will lead to a couple of pounds of weight gain early in the treatment that is not sustained, or it doesn't, continue to lead to additional weight gain. But they were able to design a study that was comparing lithium with valproate or Depakote that was short enough to where Depakote didn't cause weight gain, but lithium did. And you and I know that Depakote is one of the worst medications for weight gain. of all in the arsenal. And I think there was another study that you're probably familiar with that you may have even advised me on unknowingly, comparing lithium's impact on chronic kidney disease versus all of the other bipolar treatments.
Two studies, they're both really large. One of them compared it to Depakote, and there was no difference on kidneys. The other compared it to all other mood stabilizers, and there was no difference on kidneys. So both were huge, like millions of people found no difference. Well, that's really interesting about El Malakai's study, because I didn't know about that, but that makes sense that there can be a little water weight. I do tell patients, I think if you have side effects, you want to tell patients how much they can be in control of it and how much you can help with it. And with lithium, I tell them, don't drink caloric beverages because lithium is going to make you thirsty. And if you drink sodas or even diet sodas, which shift your metabolic balance, you're going to gain weight with it.
One of the most relevant and helpful specific clinical points that you've emphasized repeatedly on your podcast and that I've adopted into my clinical practice and patient education is that lithium, we don't know exactly how it works. There's a lot of things that we do know, but what I think that we know is that it works best as a prophylactic. Now, you have pointed out how the clinical research findings significantly differ when lithium is studied in a short time frame versus a longer time frame extending out 3 or even 6 months. Can you tell us a little bit more about the difference in clinical findings when lithium studied short term versus long term?
Yes. So let's take depression and bipolar disorder because it's used in both. In depression, we have a lot of options that work when antidepressants don't. Most all of them have only been studied short term. Say the antipsychotics, there's only 4 long-term antipsychotic controlled trials, and 3 out of 4 of them it didn't work. Ketamine, ECT, TMS, these are mostly short-term interventions, and they probably work better than lithium short-term or about the same or better. But now let's shift to the long-term. Lithium has it's over a dozen, I can't remember if it's 12 or 20 controlled trials long-term in depression where it prevented future depressions. And the most illustrative of those to me is looking at people after ECT. So this is clearly an intense intervention we only use for severe depression when nothing else works. I'll bet a lot of these patients even tried lithium and it didn't work. So nothing was helping these people get better in the short term. They gave them ECT to get better. And then they gave half of them lithium with their antidepressant to see if it kept them out of depression. And it did very well. For a whole year, if you remove the ones who went right into depression after stopping the ECT before the lithium could get to a good level, it was like 80 or 90% prevention rate over that year, which is about double what we'd expect without lithium for ECT. So it's keeping people well who are very hard to keep well. And with bipolar disorder, we see in medicine, we use like the number needed to treat to test how effective something really is. And the 2 treatments with the best number needed to treat for long term for prevention of everything, mania, depression, are lithium and quetiapine. So here we have another situation in bipolar where the antipsychotics, which are the most commonly used treatment, they work quickly, but they're not very good at prevention. So I mentioned quetiapine, we'll hold that thought, but most of the antipsychotics do not have robust prevention data. When they do try to prevent things like, I think it was cariprazine recently had a large study, it didn't work at all. And all these large studies are done by the manufacturer, so they have the bias built in that they'll try to yank away the medicine after about 2 months, like to prove that you need it forever. What? You can't do with it after 2 months? Well, then you're going to need it forever. But we know if they wait 6 months, give the person more time to adjust, they generally don't need it. So they're already trying to favor their med there.
Went to a Vraylar drug dinner one time when I was a resident, and it was 1,000 patients in the study for bipolar depression, and they got to the side effects slide. The 500 in the placebo group, there was one person who was reported to have sexual side effects, and of the 500 in the Vraylar group, there was 0 people that reported to have sexual side effects. That made me so much more skeptical than I was at the time of some of these research findings, because I know If you ask 1,000 people who have taken a placebo and Tylenol about sexual side effects, you're going to get the report of 10 to 15%, regardless of what that treatment is. So that was just I wanted to interject that
Oh yeah,
because
that's a
you brought
great
up
example.
cariprazine or Vraylar. They sent in their meanest researcher and said, you didn't have any sexual side effects, did you? But
Yes, yes. Can I share a screen?
sure.
Okay, because then we'll get some data in here. We'll have some fun. So back to this quetiapine facet. I've mentioned that of all the antipsychotics in bipolar disorder, quetiapine, Seroquel has the best preventative data for depression and mania. And it's neck and neck with lithium. I'm going to get to why I prefer lithium in a minute. But to your point, what do we do how certain are we of things? I want to show you a study that came out last week that shocked me because of all the data I've just presented to you. This runs in the face of that. So let's look at the other side. So this is a study from England that looked at lithium and quetiapine in regular depression, actually treatment resistant depression. So they weren't responding to anything, and they added in either lithium or quetiapine to the antidepressant. And what you see here, it's an entire year, and the blue line, the quetiapine line, gets much better than the lithium line. So here we have a long-term study where another med is doing better than lithium. And not only that, but here it's the opposite of what I shared with you, that the first 2 months, lithium, the red and the blue lines are about overlapping. So for the first 2 months, they look the same. And it's only in the long term that quetiapine really shines. And this is from what I do is I post a research update every day on social media to keep doctors updated. So that one was puzzling. But if I interpret that in the context of bipolar, where quetiapine also shines for its preventative benefits, I think that med's got something going on. And those of us who use quetiapine know that it's unique for its anti-anxiety properties, its ability to deepen sleep quality rather than just being sedating without deepening sleep. So it has some unique benefits. I do a lot of consultations, and one of the most common consultations is the question, patient wants to get off quetiapine, there's weight gain, sedation, and they're not able to. We've tried to replace it with everything, and we can't replace it with anything, and they get more depressed or more anxious. Well, that study shows you how powerful that can be. But why do I prefer lithium even when it's neck and neck is a couple of reasons. One is that it has long-term data where it's shown to improve functional outcomes. And that's really important because we don't want to just treat a rating scale, but we want people to actually have better social lives and job lives, fewer hospitalizations, fewer legal problems, and all of that comes with bipolar. So in large studies, like one of them looked at adolescents for 10 years. After 10 years, it was only the ones on lithium who had fewer of these problems. A lot of these are not as well controlled. And going back to, I guess I should put a caveat to what I started with. I started with saying that these are the things we look for scientific certainty. But an error would be to only look for scientific certainty, because then you're looking through a microscope and you can't see the big picture. In other words, you're only looking at 4 to 8 week studies where these studies that are scientifically certain are so expensive to design that you're only going to know about what happens for the first 1 or 2 months of your patients' lives. So when we look at longer term, now we're talking 2 to 5 years, 1 to 5 years studies, lithium tends to surpass the others. In fact, there's one study comparing it randomized controlled for a whole year, which is rare for a controlled trial, to quetiapine in bipolar. And they had overall the same outcomes, but lithium had better cognition. So that was impressive, and better neuroprotection. And that's the third reason I favor lithium, is that as a doctor, and I think patients agree with this, I want to try to treat the underlying cause of the illness as best I can. That's frustrating in psychiatry. Unless we find low thyroid or low folate, we're rarely able to do that. And I'll tell you 3 ways that lithium might treat the underlying cause of mood disorders. One is the closest thing we found to the genes of bipolar disorder, and these are important in depression as well, is the circadian rhythm genes don't function properly. Lithium normalizes the expression of those circadian rhythm genes. 2 is they now take what are called pluripotent stem cells, which are kind of embryonic cells from a person with bipolar disorder that they've then allowed to turn into neurons in a petri dish. It's very science fiction, and it is science fiction, but it's real. Anyway, they give these cells different drugs. And when they give them lithium, it normalizes the hyperexcitability of the quote bipolar brain cell. So that sounds pretty close to the cause of the illness there. If people with bipolar, if their brain cells are more hyperexcitable and lithium normalizes that, that's profound. And the third way is that lithium causes more neuroprotection, so brain growth and strengthening throughout the entire brain than any medicine in psychiatry. And bipolar is one of those degenerative conditions where the more episodes you have, the more kind of brain shrinkage down that you have.
Is it reasonable to say to your patient that lithium over time alters their electrical baseline?
You mean that hyperexcitability state?
Yeah.
Yeah, I think that is. I wouldn't use the word electrical just because it sounds a bit like Frankenstein, but
Yeah.
I think patients can relate to hyperexcitable. That's, when I read these
Yeah.
basic science studies, I'm always like, oh, H2 photoplasmic variants. I'm like, who can relate to that? But when I read that the bipolar brain cell is hyperexcitable, patients feel very overreactive and hyperexcitable. They can relate to that.
Yeah, Seroquel or quetiapine, it's a really effective drug. I think what prevents me from using it more often is just the side effect profile. I've had a lot of trouble with metabolic syndrome. I mean, I'm thinking of a patient right now who started on a relatively low dose of Seroquel for sleep, and his A1C, a marker of average blood glucose over the last 3 months, in a 3 to 6 month period, jumped 6 or 7%. And then we took him off of it and actually replaced it with another medicine that is implicated as causing even more weight gain in olanzapine. And his A1C dropped back down significantly, not to pre-diabetic level, but those instances are really powerful in terms of how I evaluate the data that is, out there on the population level. But I love to see things kind of reflected back with my actual clinical experience. One of the most satisfying things, and I really think that I would have burned out of psychiatry if I didn't start using more lithium, are the people who have this super response to it. Within a week or two, they have a noticeably uplifted mood, and that stability, I'm very skeptical of it every time somebody tells me that, and I want to see it last 6, 8, 9 months. But I've seen a lot of those patients. I think the more likely outcome that I see is kind of a gradual building effect of the medication over time, whether it is, adjusting that electrical baseline through its ionic mechanisms or its gene regulating mechanisms, its ability to decrease inflammation through GSK3 beta. But my question for whether it be bipolar, whether it be major depression, or a number of other conditions that it may be helpful in at lower doses, is the dose or the blood level more important, or is the length of treatment more important?
Yes, excellent. So both are very important. The lithium does have acute benefits, like you just spoke of, and long-term benefits. And I think it builds up over time. We know from studies looking at it long-term that if you keep the blood level a little too low, by which I'm talking about like 0.4, there's a much higher rate of depressive relapse. That comes from a study by Rick Weisler and colleagues comparing lithium to quetiapine, actually, in bipolar disorder. It was one of those studies that found the two were very similar, but that's only if the lithium had good levels. So I think the good levels are important for long term as well as short term. Part of what you might be alluding to is, could you get a good effect from lithium just from taking a low dose for 20 years? Could it build up to some kind of remarkable investment for the brain? And that I don't know. It's never really been studied outside of studies of lithium in the water, where we know that low amounts of lithium in the water reduce the rate of suicidality, violence, mental illness, dementia. It looks that way. We're not certain of that, but it looks that way. So there might be something going on, and that might have to do with the neuroprotective factors that kick in at a low dose. So it is true that in the dementia studies, they're studying lithium to prevent dementia. And in those studies, they're using low dosages. So there might be something there.
Yeah, I'm really curious because of my conversations, extensive conversations with Rif El Malik, who is somebody who's so much better at conceptualizing and visualizing these, microbiologic processes or things happening on a cellular level, so much better than I am. And, he, I think, ascribes to, at least in part, to the ion theory around lithium, in that it essentially tricks cells that it's sodium. And so it's able to get into the interior of the nucleus of the cell, but then it is not able to easily get out of the cell, is my understanding, secondary to what Dr. Al-Malik told me. So when I consider that facet, along with some of the studies on initiating lithium early in youth treatment, for those at risk or that have already declared themselves having manic and depressive episodes, it makes me think, if what he says is true, that lithium will accumulate in its impact over time. I can imagine there has to be a way for lithium to get out of the nucleus of the cell, even if it is not able to go out the sodium export transport pump. But with that in mind, I don't know. I'm curious to see what happens throughout my career over time in the research and with patients who take these low doses. But that's kind of where conceptually I'm thinking that it might have the ability to build over time in those that maybe it does not seem that it's working. If we were able to maintain them for multiple years on it, that we may just not be noticing that there is a gradual reduction in symptom severity or frequency over time.
Yeah, that seems believable. And you might consider low dose for prevention. If your parents have bipolar disorder and you're showing a little mood problems that or just want to prevent it, that's possible. Yeah. I know a doctor in New York who gives a low dose like 150 to everyone with substance use disorder. But it all needs to be published and controlled to see. So these are all good ideas that we await the controlled trials on to test out.
I use a lot of low doses, and I've certainly seen some restitio ad integrum, right? The super response to it, even at those low doses in some people. And I admit to my patients, I'm probably more likely to underdose this and to take time in order to help control your symptoms. But if you stick with me, then I can likely help to reduce your symptoms, but I'm not in a rush to do so, in certain cases. One
Excellent.
of the I was going to ask you about Selexin and the lack of use of effective treatments that are not patentable here, how the United States, we don't have treatments approved that have the data and evidence and are used elsewhere. If you have a minute to comment on that, and then any kind of final thoughts.
I just want to acknowledge to listeners who are in practice, it can be scary to try things that your colleagues are not trying, that are not seem like the norm. To me, that's not that way. To me, it's scary to give people with bipolar disorder antidepressants. That's what everybody's doing. It's like everybody's doing it, so it must be okay. It's not okay.
Especially when they're already suicidal.
Yes. So think about what you're doing and compare it to the research, not to what your colleagues are doing, and shift your fear factor, because medicine is replete in history with colleagues doing things, whether it's high dose antipsychotics in the 1970s, frontal lobotomies in the 1960s, that we probably shouldn't have been doing. And taking a history view of medicine has given me that perspective that we're just wrong so many times. So try to keep up with the numbers, the evidence. And when you do that, you'll come upon now and then treatments like you just mentioned, Selexin, Lavender, which none of my colleagues are using. Well, not none, but in America. But let's turn the tables. Let's go to Europe, where it's approved by regulatory agencies in 13 countries. It's approved for anxiety, this lavender oil. When I talk to European doctors, they are cynical about lavender in a different way. They've seen too many lavender drug reps. And they're like, not another one. I've been to some of those lunch conferences. Lavender treats everything. And in America, they're cynical about it because they think it's not a pharmaceutical product. So just throw aside your biases. And, we all have these cultural biases like MAOIs or heavy duty medications. They're not. People have about the same side effects on them as they do on SSRIs. They just have to watch their diet, but they're about as well tolerated day to day as an SSRI. They're not, quote, heavy duty. There is no paper in the world that'll tell you a medication is heavy duty because it's a BS terminology. So wash this stuff out of your mind that lamotrigine is light and lithium is heavy, and just look at the numbers and what are the chances it's going to make a difference for your patient. So let's get to that on Lavender. That's what it was. Bob Post, one of the former directors of NIMH, who shared the research with me. And what I saw in that 600 or so person study with anxiety was it was getting 2 to 3 times the response rates compared to the American medicine for anxiety, paroxetine, Paxil, 20 milligrams. And I thought, well, there must be something there. So the next step is to try it out in practice. In this case, I was able to find the actual product they use in Europe because they had licensed it. It is a pharmaceutical product, a pharmaceutical extract, but they licensed it to an over-the-counter brand called Calmade in America. And if people are interested, they can go to my website, chrisaikenmd.com/supplements. That's where I keep lists of all the dosages and supplement products that were clinically tested. So I tried it out in practice, and this was the story. Now I'll get into stories away from the numbers. I'd get callbacks, and I don't like callbacks because they're usually negative, especially from the relatives. They're like, what did you give to my sister? She's off the wall. She's abusing it. But I get callbacks from relatives saying, what did you give to Susan? Because she's not the same that she used to be. And I want some of it. She's calm for the first time in her life and not worried all the time. I'd have patients give it to their relatives for Christmas presents, Lavender. Like, that's one odd thing about it to be aware of, because it is over the counter. You can't control it. People just take it and run with it. I treated a couple thousand people with it, myself and my colleagues together. We didn't see any adverse effects other than lavender flavored burping, but we did see big effects in anxiety that it made a really big difference for people, where American meds, we all know, tend to have a small effect for anxiety.
Absolutely. Well, I seriously appreciate the time that you've given me today. And, I kind of followed the conceptualization of the brain and mental illness that we all have a mind, which to me is located in our limbic system, is our supercomputer that is trying to protect us in a world of absolute information overload. So we're getting so many false alarms from our mind, which presents things in a kind of ones and zeros binary type of system, but focuses on problems. So I often counsel my patients that your internal dialogue is probably not meant to be that positive. Now, the positive thing is that you may get ideas that will promote your survival. But anyway, all of this is to say that I make a point to consciously address and state out loud that what you've been doing in the field of psychiatry is so important, so meaningful, and such an awesome service for people like me. And I really do appreciate it.
Well, thank you. It's great to talk with you today. Let's keep in touch.
Absolutely. I'll try and steal another hour of your time at some point this year or next year.
Happy to. You take care. Bye-bye.
All right. See ya.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.
Or, put more simply,
If you need help like this guy, call your own doctor.
thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.